Hello, my name is Sandy Ramos, and I'm a clinical professor in the Division of Maternal Fetal Medicine at UCSD. And I want to thank the organizers for the opportunity to speak today on diabetes in pregnancy. I have nothing to disclose. Here's an outline of my talk. We're going to be talking about the epidemiology of diabetes, the neonatal risks associated with diabetes in pregnancy, the importance of preconception control, and specifics regarding management, what's normal in pregnancy and what the treatment should be, and some further ACOG recommendations regarding what medications to use in pregnancy. So it is not surprising to this audience that there has been an increased risk in the prevalence of diabetes. This is data from the Centers for Disease Control National Diabetes Statistics from 2020 that demonstrate that since 1999, we've seen an increase in the total number of people being affected by diabetes. But I think what's particularly concerning is that there's also been a rise in diabetes among youth. And so this is data, same from the Centers for Disease Control, among different ethnic groups. Here in the light blue is Caucasian, in the darker blue, Black, and in the purple, Hispanic. And you can see that, yes, we have seen a slight incidence in the rate of type 1 diabetes among people aged 0 to 19 years of age, but this increase is more significant for type 2 diabetes. And you can see that that line is continuing to go up. Obviously, this is concerning because children with type 2 diabetes then become adults with type 2 diabetes, and it's something that we're going to be dealing with more and more as we continue to care for the population. And closely tied to the incidence of diabetes is, of course, the prevalence of obesity. And it saddens me now that when I look at the map of the US, you can see that they've added different categories. So before, the map would end at 30% of the population being obese in a particular state. And now they've added greater than 40%, which is the very dark red here, particularly in the South and Midwest. And you can see that Colorado is probably the only state that's doing well with obesity prevalence around 20 to 25%. We also know that the prevalence of gestational diabetes is going up. And when you compare the prevalence here in 2016, this is some recent data, you see that it's gone up and nearly doubled in 10 years. And it doesn't discriminate with regards to ethnicity. And we are seeing, particularly among ethnic minorities, a rise in the prevalence of gestational diabetes. And of course, not surprisingly, just like we see with the prevalence of type 2 diabetes, we see that obesity is the main driver here in this darker blue column of the incidence of gestational diabetes as well. And then when you look at income levels, we see that again, the prevalence of diabetes really affects all income levels proportionately, if you will. So it affects everybody, but more so if in people with low income levels. So in 1952, Dr. Pedersen was the first to hypothesize that diabetes was associated with adverse outcomes in neonates born to mothers with diabetes. And what he proposed was this model where hyperglycemia in the mother led to then fetal hyperglycemia, because obviously glucose crosses very freely through the placenta, then induces fetal hyperinsulinemia and leads to some of the downstream effects, including macrosomia. And now there's good biologic evidence showing that indeed there is the development of fetal hyperinsulinemia by measuring umbilical cord C-peptide, which is a precursor for insulin secretion in the neonate. We do know that insulin does not cross the placenta. But also notable to mention is the risk of congenital anomalies, which is about 6 to 10% in those with diabetes, where in the general population is estimated to be about 3%. But things that are most commonly affected by hyperglycemia are the heart and the neural tube development, such that when we look at neural tube development defects, it occurs in 1 to 2% of mothers with diabetes, as opposed to 0.1 to 0.2% of the baseline population. And of course, one of the sort of old pathognomonic anomalies associated with hyperglycemia was saccharogenesis or CAUDA regression. And we think that hyperglycemia leads to birth defects due to high oxidative stress, which then leads to early cell death or apoptosis, and also interferes with the proliferation of cells. This can also lead to altered gene expression, which then allows for deviation of the normal development in the embryo and in the fetus. I also want to review the timing of fetal anomalies, because I think this leads to my topic of preconception control and how important it is. But spina bifida occurs as early as 6 weeks. Same thing with anencephaly. And here is a 3D image of a fetus with anencephaly. You can see on the top of the fetus's head here, it looks like a little hat on top of the head, but that's actually the brain that's sitting outside of this fetus's skull, which is consistent with anencephaly. Next is cardiac defects, which again occur very early. Transposition of the great arteries as early as 7 weeks, and then ventricular septal defects and atrial septal defects as early as 8 weeks of pregnancy. And again, this is an ultrasound image just to orient you. Here are the ventricles, up here are the atria, and this is the wall here of the intraventricular septum. And you can see a hole here and blood flow coming through in this fetus with a VSD. And one of the more sort of aggressive abnormalities that we can see with diabetes is what we call atrioventricular septal defect, where there's literally a defect in the wall of the ventricle and in the atrium here. So you see this area here with tons of color flow, because again, this fetus has a very severe abnormality. And then when we think about other organ systems, because not only can hyperglycemia affect the development of the neural tube and heart, but also the kidneys at 7 weeks. And so these are so early that preconception glycemic control is really the main intervention that we can employ to prevent birth defects. This is a reminder of an A1C table, just so that we can remember what an A1C really correlates to, because oftentimes we throw the numbers around. But I just want to point out that an A1C of 6 means an average blood sugar of about 126, whereas an A1C of 9 is about 212. And we know from older studies, this was an old study I like to quote from 1989, that shows that the risk of malformations is very closely related to the A1C. In this particular study, if a mother had an A1C of greater than 11, there was a risk of birth defects of as much as 25%. I do also want to warn you that we can't always pick up all the birth defects on ultrasound. There's some that are not routinely able to be picked up. And the American Diabetes Association recommends an A1C of 6.5 or lower preconception in order to minimize the risk of birth defects. We also know that there's a higher risk of miscarriages in this population. So overall, the rate of miscarriage is about 13%. In this study, which was dated in 2014, the risk of miscarriages in patients with type 1 and type 2 diabetes was about 20%. And again, many of the things that I mentioned with regards to how hyperglycemia leads to birth defects is also associated with the risk of miscarriage. We know that there's a release of these inositol and arachidonic acid and prostaglandin abnormalities, which all increase free radicals and can lead to miscarriage. But I think some of the more sort of conspicuous things that we see if a mother does not continue to control her blood sugars in pregnancy is the development of fetal overgrowth. Dr. Pedersen, again, to quote him, said most conspicuous is the obesity that's seen in these babies. They're awfully cute, but they have cherub's cheeks and buried eyes and a short neck. And so controlling fetal growth requires meticulous blood sugar control throughout pregnancy. And some of the other downstream effects of macrosomia and exposure to hyperglycemia is the development of hypoglycemia. Remember how I mentioned that these fetuses have hyperinsulinemia, so when they're born, they can have severe hypoglycemia, particularly among patients with type 1 and type 2 diabetes. And remember that neonates are very sensitive to glucose levels, and severe hypoglycemia can be associated with seizures and adverse neurologic outcomes. We also know that these fetuses, because of the oxidative stress, can develop polycythemia, which then after birth manifests as hyperbilirubinemia. There's also evidence to suggest that poor glycemic control is associated with respiratory distress because there's a lag in prostaglandin release in the lungs. And of course, this high oxidative stress environment can place the fetus at a risk of fetal demise. Moving away from some of the shorter term outcomes, we also worry about some of the long-term outcomes in the offspring of mothers with diabetes. So Dr. Barker was the first to hypothesize that what happens in the womb can affect what happens later in life. And he did a study among men with metabolic syndrome, coronary artery disease, and diabetes. And he took a cohort of men with these conditions and then compared them to a cohort of normal men and looked back at their birth certificate and noted that the men who had these adverse outcomes later in life had fetal growth restriction in the womb. And so that's termed the Barker hypothesis, where fetal growth restriction places a fetus at risk of later development of adult conditions such as metabolic syndrome, diabetes, coronary artery disease. And this has been shown in animal studies as well as in human studies. But we think this is a U-shaped phenomenon such that infants that are born large or macrosomic also have a higher risk of developing adolescent and adult obesity, and of course, metabolic syndrome and type 2 diabetes. And so we think of this as being a U-shaped phenomenon such that undernutrition or overfeeding in the womb increases the risk of adult obesity. And this is a plug for breastfeeding, which seems to modify this risk. We also have some very good prospective data showing this relationship. This is a study that's a classic study published in 2005 where Dr. Boney followed patients, a cohort of patients that had gestational diabetes and women who did not develop gestational diabetes, and followed them for about 10 to 15 years. And she also followed their children. And one of the things that they noticed was if you were born large for gestational age and your mother had gestational diabetes, at the age 9 to 12, you had a prevalence of metabolic syndrome of about 50%. That is astounding. However, if you were born appropriately grown, meaning normally grown and no diabetes, or even exposed to diabetes, the rate of metabolic syndrome was about 20%. And again, this is very similar to that of the control group. So again, trying to avoid the development of macrosomia is very important for the overall health of this neonate. And so this is a very simplified model of diabetes begets diabetes, such that high maternal fuels leads to altered fetal islet function, which we talked about as manifesting as hyperinsulinemia, which then leads to childhood obesity, adolescent impaired glucose tolerance, gestational diabetes, and pregestational diabetes. So now we're going to shift from the importance of why we do the things that we do to how we manage glucose in pregnancy. First, we need to define what normal is. And this is what we know to be normal currently. I have to let you know that there is currently a trial underway utilizing continuous glucose monitors in pregnancy to really define what normal is across gestation. But this is what we follow here in California. This is a study by Dr. Peretti. He conducted the study in women who were pregnant and did not have diabetes at 28, 32, and 36 weeks. And what you can see is here is morning time, and then breakfast, lunch, dinner, and nighttime. And you can see this very particular pattern, which is that the fasting glucose values range normally in pregnant women. even at this key time of insulin resistance, about 60 to 70, so mostly below 80. In between meals, it's usually somewhere between 70 to 90, as evidenced here. And then the peak postprandial is rarely above 110. Of note also, the peak postprandial seems to be 90 minutes after the first bite of food, something to keep in mind when you're thinking about controlling glucose values. We also know there's some characteristic findings that occur in early pregnancy as well as late in pregnancy with regards to insulin sensitivity. So this was a study done by Dr. Catalano, where he took women who were planning to get pregnant, had a group of control women as well as women who ended up delivering or manifesting, gestational diabetes, and he looked at insulin sensitivity. And you can see that the women who were destined to develop GDM already had a baseline difference in terms of insulin sensitivity. So we think there's some sort of multifactorial predisposition to developing GDM. But then you see that in early pregnancy, insulin sensitivity, which is on the y-axis here, actually goes up. So women are more insulin sensitive in the first trimester. And that's going to be important as you manage women with type 1 and type 2 diabetes. And then late in pregnancy, you see that the insulin resistance for both groups increases. In other words, the insulin sensitivity goes down, but more so among the women who were destined to develop GDM. And there was a statistical significant difference between the controls in the red and the moms who developed GDM in the blue. And so we think that this is mediated by different etiologies. Hormonally, we think of human placental lactogen as leading to this, estrogen and progesterone changes, but there's also weight gain in mothers, which can predispose to insulin resistance, as well as an increase in free fatty acids, which we know is meant to facilitate, nutrients to the fetus, but can also be associated with insulin resistance. So this is a physiologic adaptation, of course, of pregnancy to allow or facilitate glucose and nutrient transfer to the developing fetus. But in women with GDM, it goes on overdrive. So what are the goals that we use? Here in California, we're using a fasting glucose of 60 to 89 or less than 90, pre-meal somewhere between 60 to 99, and peak postprandial of about 100 to 129 or less than 130. We usually recommend checking that peak postprandial at 1 hour from start of the meal, because as I mentioned earlier, it appears that the true peak is occurring at 90 minutes. So if you check a blood sugar at 2 hours after the start of a meal, you may be missing that peak. And so that's why we choose the 1 hour at our institution. I just want to note that the American Diabetes Association recommends less stringent goals. So a fasting less than 95, a 1 hour less than 140, and a 2 hour less than 120. And again, I have hope that we are going to fine tune these recommendations probably by trimester based on the data that will be coming out of that trial I mentioned. We then teach our mothers who are diagnosed with diabetes already or who are diagnosed with gestational diabetes on how to eat appropriately to prevent hyperglycemia. And so we generally recommend of the total calories eaten that 30 to 40% correspond to carbohydrates. And again, we recommend decreasing simple carbs and replacing them with complex carbs. 20% of the meal should be lean proteins and 40% fats. And we're hoping to use fats that are plant-based or fats that don't have saturated fats. And then we teach them carb counts. So we are mostly insulin resistant in the morning because we're going through an overnight fast. So we usually tell them a lower carb count, so about 30 to 45 grams of carbs for breakfast, and for lunch and dinner, 45 to 60, and for snacks, 15 grams of carbs. We also recommend exercise, 30 minutes of moderate to intensity aerobic exercise 5 times per week. So a good exercise regimen is to go walking after each of your meals. And we recommend a minimum of 150 minutes per week if possible. And this is something we really try to engage our patients in because it can really be a powerful tool to lower hyperglycemia after meals. And then we recommend, as you guys know, glucose monitoring for type 2 diabetes patients and gestational diabetes. We usually recommend fasting glucose values as well as 1 hour after meals, although we have been using continuous glucose monitors more and more, including the flash glucose, continuous glucose monitor with the Libre. And then for type 1 and diabetes patients, we do recommend more frequent monitoring, so fasting, preprandial, and 1 hour after meals, and then of course at bedtime. But the continuous glucose monitors have now been a game changer for the management of our patients with type 1 diabetes, and we're utilizing them more and more. Please note though that the continuous glucose monitors have not been FDA approved for use in pregnancy. As you know, the treatment of choice for overt diabetes and gestational diabetes is insulin, and we'll touch a little bit on the oral hypoglycemics in this lecture as well. So the insulins that we tend to use the most in our clinic are the short-acting insulin analogs such as Lispro and Humalog, because they have a very quick onset of action, and the peak duration is a little lower, so that it decreases stacking effect of insulin. And then we tend to use NPH for preprandial and fasting glucose control, as well as some of our patients will be on longer acting insulins. And this is not an extensive list of the insulins, but just gives you an idea of the onset of action and the peak of action. I just want to point out that Lantus, we have to be careful because it doesn't have a peak of action and the duration is quite long. We generally calculate the dose of insulin based on the patient's trimester of pregnancy, so first, second, and third trimester, and the dose according to the gestational age. One of the handier tools that I've come across is perinatology.com, which you can plug in the patient's current weight, her insulin dose based on where you see the patient. So for example, if she's an obese patient with type 1 diabetes or a type 2 or uncontrolled GDM, and she's 25 weeks, you can put a range somewhere between 0.9 to 1.2, and the total daily amount of carbs, which is usually recommended to be 225, and then it'll calculate a dose for you. If you're starting insulin on a type 1, which is extremely rare, but every once in a while I have a patient with type 1 who is her regimen just is not working, and I want to start sort of from the beginning. Sometimes I'll utilize this tool to kind of get a sense of what she should be using. And then in terms of choosing the insulins, again, we like the short acting because regular has to be taken about 30 minutes before, given the onset of action, to allow for control of that postprandial glucose value. And Lispro, for example, or Humalog or Novolog, you can just inject it at the time that you begin eating. It has little effects after 2 hours, so it's very ideal for pumps, insulin pumps, and for patients with type 1 diabetes, but it's also very user-friendly for patients that have, for example, very busy work with unpredictable meals, for example, doctors and nursing staff. And then we use NPH, like I mentioned, to control pre-meals as well as to control fasting plasma glucose. But we do recommend giving the NPH not at bedtime, but at 10 to 12 p.m. to avoid the dawn phenomenon. And just something about Lantus to consider is it doesn't peak, and so you have to be super careful about interprandial hypoglycemia. And so here's a figure that I borrowed from Dr. Moore, my mentor. Here's the plasma glucose value. On the x-axis is the time of day, and you can see here this mother has breakfast, lunch, and dinner meals. And so the way we usually dose our insulins is we usually use NPH at 10 p.m. or later to treat this fasting blood sugar here in the morning. We want to avoid it peaking here during the dawn phenomenon. And then we give Humalog with breakfast and with dinner, and then AM NPH to cover the preprandial lunch values and hopefully have her go into the meal better. But sometimes we do need Humalog added for that meal as well, depending on the timing of the meal and multiple other factors. And then again, Lantus, just beware that it can affect the interprandial blood sugars. And then the other thing I want to point out is sort of the insulin resistance that I mentioned earlier, but this is what we call the relentless escalator of insulin resistance. Note that for your patients with pre-gestational diabetes, so on the y-axis is insulin dosing, on the bottom is gestational age. You can see that in the first trimester, we have an increase in insulin sensitivity, and so therefore we need to back down on insulin by as much as 10 to 15%. And then later on, we see a rise in insulin resistance where it's a vertical rise, such that when we studied our patients with type 1 diabetes who were in really good control, they needed as much as 50 to 300% more insulin than they did at the beginning of the pregnancy. With type 2 and GDM, similarly, they needed about 100% increase in their insulin requirements at the peak insulin resistance stage of pregnancy. And notice that after 36 weeks, we see a decline in the insulin resistance. So something to keep in mind, again, when you're managing the insulin in these patients. Sometimes we have to peel back at around 37, 38 weeks. We generally instruct our patients to call us every week or email us every week so that we can increase her insulin regimen weekly. Sometimes we need to do it 2 times a week to find that perfect threshold if somebody's experiencing very marked insulin resistance. And we usually increase by 10 to 20% or by as much as 4 to 8 units each time. And then, of course, the American Diabetes Association did publish their algorithm for management using continuous glucose monitors. And you may have seen this in their clinical practice guidelines. But here for type 1 and type 2 diabetes patients, you can see that the target range that they recommend is somewhere between 70 to 180. And that you want to keep that patient in that target greater than 70% of the time. You want to minimize hypoglycemia to less than 4%, and they define hypoglycemia as less than 70. And you want to minimize hyperglycemia as well, and they define that as greater than 180. I can tell you that in our type 1, oh, I'm so sorry, I was showing you the non-pregnant type 1 and type 2 diabetes patients. In our pregnant type 1 diabetes patients, they define the target as 63 to 140. And again, we want to achieve greater than 70% target range blood sugars on the continuous glucose monitors. And then for our pregnant gestational diabetes and type 2 diabetes patients, we want, again, to maintain this range 63 to 140 in the majority of time. And so I utilize that with the patient. I literally show it to her and say, hey, look, you are at 40% target range. And so we need to work on getting that higher while also minimizing the hypoglycemic events. So I utilize this information. This was mainly data driven by the CONCEPT trial, which showed an association with a lower rate of macrosomia with a target blood sugar range in this 70% range. Now we're going to move over to oral hypoglycemics, and there's different ways that oral hypoglycemics work to lower glucose in the body. And this is a very old slide because it doesn't have so many of our newer oral hypoglycemics. But remember that none of the oral hypoglycemics that are now on the market have been approved for pregnancy use and have been studied in pregnancy. The one that has are Glyburide, which is an insulin secretagogue or sulfonylureal, and then a biguanide, which is of course metformin, which increases muscle uptake of glucose. The concern always with the oral hypoglycemics is the risk of congenital anomalies, but also direct stimulation of the fetal pancreas, resulting in fetal hyperinsulinemia, which people feared would lead to macrosomia and hypoglycemia. So the first oral hypoglycemic that was studied was Glyburide in 2000, 22 years ago. They randomized women with GDM after embryogenesis, so at the usual time, 24 to 28 weeks, to either Glyburide or insulin, and they found no differences in glycemic control, overall neonatal outcomes, and umbilical cord C-peptide. But recently, you may have seen a lot of meta-analysis being published on the use of Glyburide in pregnancy, showing a possible increased risk of macrosomia as well as neonatal hypoglycemia. One of the thoughts is that perhaps we're underdosing the glyburide. This is the pharmacokinetic analysis of glyburide in pregnancy among women with GDM, which is here in the dark line, versus women with type 2 diabetes. And you can see that the overall dose seems to be underdosed in women who are pregnant. And one other additional finding of this trial was that glyburide does cross the placenta. They were able to assay it with a much more sophisticated assay, and were able to find that the glyburide does cross the placenta. This was not an original finding of the original RCT. And the average core to maternal plasma glyburide concentration was 0.7 at delivery. The other oral hypoglycemic is metformin, and metformin was studied in 2009 by the MIG trial, which similarly randomized women with gestational diabetes to either insulin or metformin, and they found no difference in glycemic control rate, in glycemic control, no differences in the rates of macrosomia or neonatal hypoglycemia between the metformin and insulin groups. But there was a failure rate, meaning that 46% of women who were on metformin needed insulin for adequate control. Another interesting finding of this trial was that there was a lower rate of severe hypoglycemia in the mothers treated with metformin, as we would expect, but there was also a higher risk of preterm birth in the metformin group as compared to the insulin group. And this has not been demonstrated in subsequent trials, but this is the largest trial to date. The way to dose the metformin is to start with 500 milligrams BID and increase that by 500 increments to a max of 2,500. I usually recommend taking it with meals to minimize the GI symptoms, which are bloating, nausea, vomiting, and diarrhea. And there is no targeted dosing. Currently, we just finished the multi-center trial using metformin as an adjunct to insulin in women with type 2 diabetes, and the analysis is currently underway for that trial. But there was been a lot of controversy about oral hypoglycemics, and it's very complicated, and I won't go through all of the data, but just suffice it to say that glyburide has been getting a bad rap among meta-analyses of the published trials, which showed, like I mentioned earlier, a higher risk of macrosomia and neonatal hypoglycemia. Although there was a very well done study out of Kaiser, Northern California, and a very large cohort of women comparing insulin to glyburide that did not find that association, and that trial was just published this year. But in 2018, this led ACOG to say that insulin should be the first-line treatment for mothers with gestational diabetes, and that oral hypoglycemic should be deferred unless women decline insulin, cannot afford the insulin, especially nowadays when the prices for insulin have really gone up, or physicians believe that the patient cannot safely administer the insulin. Metformin is an acceptable second-line agent, and that glyburide should not be offered as first line, as it has not been shown to be equivalent to insulin. Although, again, I think there's trials underway to potentially study this further, and I'm sure ACOG will be revising their guidelines if needed upon publication of these trials. At UCSD, we do always offer insulin as the gold standard. If the fasting levels are less than 110, we may offer them metformin. If the fastings are greater than 110, again, we counsel patients on insulin as the gold standard and discuss the option of glyburide, but we are very honest about the recent concerns regarding the use of glyburide in pregnancy, although I have to say I have several patients who have used glyburide in the past and feel very comfortable using it again in a subsequent pregnancy. I want to thank you all for your attention. I would be remiss to not thank my fantastic team at the UCSD Diabetes and Pregnancy Program. First of all, my mentor, Dr. Moore, who taught me everything about management of diabetes, our diabetic educators, and I am lucky to have 6 diabetic educators working with me in our clinic who take care of over 400 patients a year with diabetes. Our nutritionists, social workers, our antenatal nurses, obstetrical residents, and MFM fellows who work with us to take care of our patients with diabetes.